So I'm going to speak to you today a little bit about a few abstracts coming from the liver meeting about non-alcoholic fatty liver and alcoholic liver disease. As Dr. Locke said, alcoholic liver disease is my area of research interest and what I work in mostly, but we tend to group these two things together. Obviously, the causative factor of fat in the liver in these two conditions is quite different, but pathophysiologically they look the same under the microscope. And importantly for all of us to realize is that these are behaviorally mediated liver diseases. So obesity with non-alcoholic fatty liver in addition to diabetes and some of the metabolic syndrome, and then obviously alcohol use and severe alcohol use disorders are the behaviors that mediate this. So important for us to understand because as Dr. Fontana pointed out, we are kind of getting rid of hepatitis C. I'm not going to say we've got it completely cured or completely treated, but all of the projections indicate that in the coming years, we're not going to see as much of this because the direct-acting antivirals are so effective at getting rid of it. And so what is rising to take its place? It's these two diseases. It's non-alcoholic fatty liver and alcoholic liver disease. And as we'll talk about, I tried to select some abstracts from a very large group of abstracts, over 500 abstracts in these two areas that might have the most clinical relevance for us right now in clinical practice and ways to think about how we care for these patients, how we diagnose, and what implications that has for us as we take care of them. So starting off with non-alcoholic fatty liver, or NAFLD. As we all know, NAFLD is really a spectrum. So it's beginning with just fat in the liver and then progressing on to those who have inflammation or non-alcoholic steatohepatitis. And in some of those patients, a percentage of them will go on to develop cirrhosis. This was an article from Dr. Allen at Mayo looking at the cardiovascular risk as it relates to gender in patients who have NAFLD. What we all know and are quite familiar with is that in general, prior to menopause, women are generally protected compared to men. They tend to have lower risk of hard cardiovascular outcomes like heart attack, stroke, AFib, et cetera. But what Dr. Allen's abstract looked at was whether or not NAFLD influences this risk separately. What we also know is in general, in epidemiologic studies and studies of cardiovascular outcomes, NAFLD gives you an excess risk above and beyond diabetes, hypertension, hyperlipidemia, smoking, those types of things, not only for hard cardiac outcomes, but also for some of the intermediate measures that we have of cardiac outcomes like coronary artery calcium, cardiac intima media thickness, or excuse me, carotid intima media thickness. So in all ways, it seems to be a separate and independent risk factor. And what Dr. Allen wanted to do was explore sex-related differences in that cardiovascular risk in NAFLD to see if women versus men had differential risk and if it tended to give you an excess risk. So this was a long-term study, again, retrospective from the Rochester Epidemiologic Project, looking back at NAFLD patients in the Mayo Clinic area in Olmsted County. And they looked at incident cardiovascular disease events after the NAFLD diagnosis. So your time point was the NAFLD diagnosis. And their heart outcomes were as they typically are in these studies: angina, myocardial infarction, heart failure, AFib, and stroke. They matched them 4-to-1 with cases and controls, and they matched them on all the things you would want to match on for cardiovascular risk. So your age, gender, and then cardiovascular risk factors, as well as any baseline known cardiovascular disease. And they had just over 4,000 subjects with a median age of about 52, and about half were women. So they had a good, well-characterized cohort. And what they found is that the risk of these incident cardiovascular events, all total, was about 1,600 over the course of this study. And I can tell you, having done one of these studies in the Framingham Health System, it can be a little bit difficult to get that number of incident cardiovascular outcomes. You really have to follow people for a long time to be able to get that level of incident cardiovascular disease. So they had enough and enough power to be able to tell this. And what they found here was that in men, the risk men with NAFLD, did not appear to increase the risk of incident cardiovascular events, but for women it did. And it increased it, and not greatly, but definitely statistically significantly up in all events to about 1.21 here. And then when they looked at individual events, angina, MI, and heart failure, you can see here that they had some slightly differential effects, but all significant for AFib and stroke. That actually wasn't significant for gender. And they also found that these events tended to occur more frequently and earlier compared to the general population. So what you're seeing here is, this doesn't project as well as I would like, but the solid lines are the people with NAFLD, and the dashed lines are their controls. And the controls, you can see, it's the progression that we typically see. It's related to age, it progresses in almost near linear fashion across age, and men greater than women as you age. But with NAFLD, it tended to here be earlier. So you had more cardiovascular events earlier, and women were greater than men here. That crossed over as they got older. So men, again, had more cardiovascular events with NAFLD compared to women with NAFLD. But both of these were higher than any of the controls up until you hit about the age of 65 when those lines began to converge. So really the takeaways here, that again, this is retrospective, so it does have retrospective study limitations, but there do appear to be an attenuation of those cardiovascular protective effects of gender. And what this means for us clinically is to be aware of this and to really focus on the cardiovascular risk protection in people, maybe even at a younger age than we might normally think about it. So checking lipid profiles and being aggressive about diet and exercise, controlling blood pressure, diabetes, and hyperlipidemia to try until we get effective treatments for NAFLD and NASH to help with the cardiovascular risks of these patients. So the next abstract that was presented in one of the parallel sessions was about, okay, so how do we find these people? So there's multiple different ways of diagnosing fatty liver, and obviously we want to not just diagnose fatty liver on its own, but we want to try to diagnose the more advanced forms as well. So NASH and obviously cirrhosis. We want to find these people. And one of the ways that has been looked at to do this is with FibroScan. Obviously, this has been used quite extensively throughout. And this study looked at how feasible was it to do this in a primary care clinic. So in people who are just walking in and don't have pre-existing liver disease, and you're looking at whether or not they have NAFLD, can you do this? And what are some of the issues with screening in a primary care clinic for this? So they looked at 3 months prospectively, all patients who came into a primary care clinic in California. So this was a population in Coronado, California. They consented just over 800 patients, and everybody underwent FibroScan in this clinic. Nobody had liver disease. They excluded people who had pre-existing or known liver disease, Hep B, Hep C, et cetera. And they used what most frequently is called FibroScan or vibration-controlled transient elastography. And this is a method of determining essentially liver stiffness. So you're looking for how stiff is the liver as a shear wave is passed through the liver tissue. And there's a calculation based on Hooke's law. We can dig that out of our physics classes from undergraduate. I knew that would come in handy someday. I didn't know it at the time, but now it has. So there's a bunch of math that gets done here. And they calculate how stiff is the liver, and in the proper context, acknowledging some of the limitations of the study, of the use of this, which we'll talk about, you can measure how stiff that liver is, how much fibrosis or scar tissue is in the liver. There also is now a relatively newer technology within the last couple of years called controlled attenuation parameter, which again looks at the attenuation of the tissue, of the tissue under ultrasound. That the takeaway from that is it gives you an estimate of fat. So you can look at both fat and fibrosis in the liver with FibroScan. And in general, the multiple studies that have been done on this technology show that it's pretty good for distinguishing kind of the extremes. So you can say cirrhosis or not. You can say a lot of fat or very little fat. When you get into kind of the gradations of fibrosis, we generally measure it F0, no fibrosis, or F4 is cirrhosis. When you kind of get into those gradations of F1, F2, it doesn't do quite as well. So we use this a lot of times to say, do you have cirrhosis or do you not have cirrhosis? And that seems to be where it functions the best. Some caveats to it are that if you're going to use it, you want to make sure that there's not going to be anything going on with the patient that's going to falsely elevate the stiffness or is going to have too much tissue or too much distance in between the probe, which sits right here between the ribs, and that liver. The more distance you have between the probe tip, which sits right at the skin, and the liver, the greater the degree of error that you're going to have with that study. So people who have ascites, we don't use it in people who have ascites. If you have heart failure and you have passive congestion in the liver, it's going to look stiffer when it may not be, just because of the backflow. If your ALT is too elevated, that can be over 100, that can indicate more inflammation in the liver, and inflammation, as you might imagine, might give you a greater degree of stiffness, not truly reflective of scar tissue. We want people to be fasting, because if you eat, it's going to increase blood flow. Again, you might have more stiffness that's not necessarily reflective of scar tissue. Very severe steatosis actually can be a confounder, so having the cap method with this can be helpful. And then obesity, BMIs 30 or above, can be confounding again because we have this distance in between the liver tissue. So there is an XL probe that comes along with this being used increasingly now. The technology of which is designed to help us be able to more accurately sense true stiffness across a greater distance in between if you have more subcutaneous tissue there. So what they found in their study was that about 2/3 of the patients were female. They're fairly young, only about 45, mostly Hispanic. And they had quite a few people who had BMIs over 30, but they didn't really comment extensively about if they used the M or the XL probe. So have that in your mind. About 13% had diabetes and 13% had hyperlipidemia. And they found that about 1/3 of people had significant fatty liver, so they were kind of above 290 on their CAP. And then for the fibrosis score, they also found that they had about 4% of people had a score of over 15, which is very clearly cirrhosis in this population. And about 12% had a score from anywhere from 7 to 15, which is consistent with advanced fibrosis, or kind of on the F3 to F4 scale. So the takeaways from this were really that it's feasible to do this in the PCP clinic, and you might actually be able to identify some people who have more advanced fibrosis and cirrhosis and then get them into appropriate screening with HCC screening protocols, et cetera. It may help your patients be motivated to lose weight. So sometimes when patients have a knowledge of negative consequence of something, so you have liver disease, you have more advanced fibrosis, those types of things can be motivational for some people, to help them lose weight. And with NAFLD and NASH, weight loss is, bar none, the best way to help this get better. So there have been studies that have been presented a couple of years ago where 10% of the body weight or greater in patients lost and kept off in paired biopsy studies led to resolution of fatty liver and NASH in as many as 80% of those patients. Generally, if they're in the cirrhosis category, that's not going to go away, but it's pretty powerful to be able to tell your patients that if they can lose 10% of their body weight or more and keep it off, they might actually see healing of their fatty liver and some of their fibrosis over time as they keep that off. They didn't really do alcohol use questioning in this, and that's actually quite important because alcohol use can, as you might imagine, cause inflammation and falsely elevate that score. So if people are using alcohol, you may want to not do a FibroScan right away on them, but give them some time in abstinence first before you go back and FibroScan them to see how much scar tissue is in the liver. And this is just a nice graphic from our own Dr. Tapper, who's going to be speaking later, on the things to know about FibroScan and kind of how to use it. The first most important thing is that you need to know what that underlying disease is, because your cutoffs for what is and isn't high-grade fibrosis or cirrhosis change based on your disease process. So as you can see here, some of these kilopascal scores for cirrhosis or fibrosis, they're different depending upon what the validation studies have shown in these various different liver diseases. So knowing that allows you to interpret that result. And again, you want to obviously pair this with your history and physical, pair it with your labs. If for whatever reason you feel you can't do a FibroScan, then you want to be considering other ways to potentially assess for advanced fibrosis, both with blood testing, some of the serologic scoring systems. We offer an MR elastography at the University of Michigan now that can be helpful for obese patients for whom FibroScan is not going to be accurate. Functions in a similar way with elastography, meaning vibration through the liver, but it's not a probe that's going to be impacted by that distance in between your liver and your skin. So that's another option if you're dealing with people whose BMI is too great and you feel it's not going to be accurate. So moving on to alcoholic liver disease. The first abstract that we'll talk about is actually one that came out of our center on looking at the burden of alcoholic cirrhosis in the United States. So as many of you are aware of, we really have a huge problem with alcohol use disorders, and there was recently a large article in the JAMA Psychiatry that looked at a very big study of the epidemiology of alcohol use disorders. It's called the NESARC, and it's a large survey study, very, very good survey study that the NIAAA, the alcohol research arm of the NIH, runs about every 10 years or so. And what they found was that the rate of alcohol use disorders in the US, the alcohol use disorder being the more severe form of alcohol use problems had gone up by 50% over the course of the past 10 years. And in women, it was 80%. So we're seeing more alcohol use problems, but because of the nature of the American healthcare system and our data sets, it's hard to really estimate how big of a problem is alcoholic cirrhosis in the US. Anecdotally, we see this a lot, and I'm sure you do too. Certainly, it's the second leading cause for liver transplant, and that's going up, not down, across the nation. There have been studies about that as well. And so our aim with this was to try to estimate the healthcare burden overall in privately insured alcoholic cirrhosis patients. So why privately insured? The Center for Medicare and Medicaid, where many of these patients are probably located in terms of insurance, had eliminated substance abuse related claims from their data set because of concerns about privacy. So that makes that data set tough to use, obviously, if you're going to be studying a very substance abuse related disorder. So we looked at a large data set called Market Scan, which is tens of millions of patients with employer-sponsored insurance across the nation. And it comes with a weighting strategy that allows you to make estimates to 50% of the US population, so 150 million people roughly, who have insurance bought and paid for by their employer. So it's a big data set, it's very well characterized, and it gets us this larger sense of what's happening with these patients across the nation. We looked at this from 2009 to 2015, and we defined it by ICD-9 codes, which is how most administrative claims data sets are done, where you look at the ICD-9 code and define it in that sense. At baseline, these patients' ages were roughly similar. So we had about 66,000 patients who had alcohol-related cirrhosis and about 100,000 that had non-alcohol-related cirrhosis. The women, there were about a third of the alcoholic cirrhosis patients as compared to about 50% of those patients who did not have it. They had long-term coverage, so we had a lot of data in terms of their coverage. And Elixhauser is a comorbidity score to detect how sick someone is in another sense, how many other comorbidities they have. And alcoholic cirrhosis patients tended to be slightly sicker than non-alcoholic. When we looked at the prevalence across this time frame, so looking at how big of a problem is this and is it growing, what we found was that it actually is growing by about just over 40% across this relatively short time frame, and that alcoholic cirrhosis patients again made up just over a third of that total burden. When we did some subgroup analyses to see was this going up in men versus women, it was slightly higher in terms of rate for women, but we found that in the young population, people under the age of 45, it had actually tripled across that time frame, even though the numbers were quite small. And this anecdotally kind of matched some of what we were seeing in our own hospital, where very, very young patients are coming in their early 30s, sometimes even their late 20s, with advanced alcohol-related liver disease, alcoholic hepatitis and alcoholic cirrhosis, even at that young age. We looked at event rates, meaning how many decompensating events did these patients have, trying to decide trying to see, are these patients sicker at presentation? And effectively, the takeaway from this slide is that they are. So when they show up with their first diagnosis, they are more likely to have ascites, hepatic encephalopathy, a variceal bleed, and kidney injury. And when we project this out to 2 years, that holds true. So they tend to have more decompensating events and to just be sicker when they're showing up for the first time, and that stays that way over time. Obviously, the data doesn't tell us this, but it makes one wonder, are we missing these patients, or are we missing these patients? Was there an opportunity for us to help them stop drinking, which might help them not decompensate as much? They're admitted more frequently, certainly, for all reasons, and also for cirrhosis, alcohol, and readmissions as well. So not only are they sicker, but they're using up more or being admitted and readmitted more, so just overall sicker patients. And in terms of the costs, when we look at per person costs, the highlighted line is for one alcoholic cirrhosis patient compared to a non-alcoholic cirrhosis patient, and it's almost double. So single patient to single patient, almost double. What you see here in the subsequent lines is an isolation of ascites by itself, so comparing any person with ascites to any person with cirrhosis without it. And what this tells us is that, as expected, these complications, regardless of where they're occurring, are costing more in these patients. And so the cost of alcoholic cirrhosis patients is really coming from their decompensation. It's coming from the fact that they have more ascites, they have more bleeding, they have more encephalopathy and HCC. And overall, they cost about over half of the total cost to the healthcare system in these privately insured patients. So it was about $9.5 billion in 2015, and just over half of that was coming from our alcoholic cirrhosis patients. So the takeaway of this was that we really have a defined now population, and even in the privately insured cohort, where we might expect them to be healthier. So again, remember, this is in people who are employed or have employer-sponsored insurance or their dependents. This isn't in Medicaid, Medicare patients or in the VA system, where often these patients might move into those systems once they become too sick to work. So we expect that this is actually the floor of the problem, and that if we were to look in CMS or VA data, it would actually get worse. We're going to see more costs and more illness as a consequence of this. So one of the other areas of debate that's been, that kind of comes along with advanced alcoholic liver disease is should we or should we not be transplanting patients who have alcoholic hepatitis. So alcoholic hepatitis often co-occurs sort of on top of alcoholic cirrhosis. This is a very severe inflammation of the liver that comes about from heavy alcohol use, and then results in a systemic inflammation and extremely high mortality, so as high as 50% at 3 months in patients who have alcoholic hepatitis. And as you might imagine, it's prompted people to ask, should we be transplanting these patients? And by way of background, one of the seminal papers that was published about 5-6 years ago in the New England Journal came out of the French study that looked at transplanting highly selected patients with alcoholic hepatitis and looking at how they did. And they did actually fairly well. So when you look at the survival curves here, looking out 1 to 2 years, about 3/4 were alive compared to those ALCHEP patients who didn't get transplanted, who actually died. So of course, as you might imagine, this is not without controversy. Not every center does this. We at Michigan do not transplant acute alcoholic hepatitis, but other centers are beginning to look at larger scale studies of how people do. And what this initial study looked at was how do these patients do compared to status 1A patients. So your status 1A patients are your acute liver failure patients who come in suddenly very sick. They get listed. They kind of go to the head of the class right away because they are so sick, and they get allocated organs first before anyone else on the list because they are so sick and their mortality is so high. So they compared these ALCHEP patients with status 1A patients to see how they did. And this group looked at 5 years of UNOS, or United Network for Organ Sharing data, which collects data on all liver transplants that occur in the United States. They compared waitlisted ALCHEP patients with status 1A patients, and they divided those into effectively Tylenol and non-Tylenol related acute liver failure, because Tylenol is the #1 cause of acute liver failure in the US. And they looked at 90-day waitlist mortality, a 90-day transplant rate, and then 1 and 5 year post-transplant survival, which are really our standard outcome metrics for transplant. And what they found was that here, if you look at the acute ALCHEP, the takeaways are that their transplant rate was actually was comparable to the non-DILI group, but greater than those for Tylenol. This may be a consequence of potentially Tylenol patients who were listed then recovering. It's hard to know because they didn't present that data. But their 1 and 3 year post-liver transplant survival were actually quite good, and in some cases, and in this study, better than those who were transplanted for ALF of whichever cause. So the takeaway from that is that the outcomes actually look like they may be just as good. In this study, that was called the Accelerate AH study, they provided us with a little more granular detail about a rather large group of patients who had been transplanted across multiple centers with acute alcoholic hepatitis. So again, the aim was roughly the same, to determine how do these people do when we transplant them. Should we continue doing that or not? And they looked at 12 transplant centers across 8 UNOS regions. Again, transplant is by region, by geographic region across the US, so they had a good coverage of the US. And they looked at a time frame of just over 10 years. Anybody who'd had alcohol use within 6 months of transplant and met the clinical definition of alcoholic hepatitis was included in their cohort. And note that they also had to have no other prior liver disease diagnosis and no prior history of alcoholic hepatitis episodes. And this gets at the choice of these patients. So what you see in these studies and in transplant centers that are transplanting alcoholic hepatitis is it is a very select group of alcoholic hepatitis patients that meet the criteria that they've assessed. And typically, if they've had any other alcohol-related liver disease in the past and drank over it, people typically won't transplant those individuals. So if they had that before, they did not transplant them here, and they looked at survival. And they also, importantly, really importantly for these studies, they looked at alcohol use post-transplant. And they did a nice job of mirroring the addiction medicine literature and looking at slips, where you go back to some alcohol use, but you return to abstinence quickly, versus relapse, where you go back to heavy alcohol use and there is not a return to abstinence quickly. One of the challenges with this literature is that frequently we conflate those things, and in the hepatology literature we put it all together. Any alcohol use is considered the same, but that isn't true, and it isn't evidence-based with the addiction medicine literature. So they did a nice job in making it evidence-based with our addiction medicine colleagues and distinguishing between slip and relapse. And they had 147 recipients with ALCHEP, 147 over 12 centers over 10 years. So that gives you an idea of how kind of rare it is for an ALCHEP patient to qualify for this. Most were male and white, 2/3 were privately insured, some of which may relate to some of the requirements for substance use that are attached to other forms of insurance. The median pre-transplant abstinence was 55 days, so much less than the typical 6 months that you've heard about, that we often hear about. Over half had received steroids before they were transplanted, and we'll talk about this a little bit later in the subsequent talk, but prednisolone, as many of you know, is used often in acute ALCHEP in certain scenarios to see if people improve, and if they do, they go on to have potentially a month's worth of prednisolone to try to help them recover from ALCHEP. If they don't, these were often the people who got into this study to be transplanted. Their median MELD was really high at transplant, so 39. The MELD caps out at 40. So these patients were very, very sick, and they followed them for just about a year and a half. And what they found was that there were approximately about 25% used alcohol afterward in some form. So at 1 year, about a quarter would have used it, but that increased at 3 years to about a third of the patients who had used it. And the median time to that first drink was about 160 days after they left the hospital. Factors that were predictive of this was a lack of self-admission at the hospitalization predictive of drinking. So if they're not saying, yep, this is alcohol, and not having that level of insight, that was predictive of going back to drinking. But the survival at 1 and 3 years was 94% and 84%, even with that level of slip and relapse. And I should also distinguish here the slips versus the relapses. Again, relapses were slightly less common than slips. If we miss a slip, it can turn into a relapse. So it's important for us to catch those types of things in our patients who have this kind of an issue. Predictors of death. Predictors of death then afterward were if you had more than 10 drinks per day prior to coming into the hospital, so the heavy drinkers, more than 10 drinks, and if you had any alcohol use at all post-transplant that was slip or relapse, that was also highly predictive, and this was really one of the only things that was predictive on multivariate analysis of post-transplant death. They had 18 deaths overall. 9 of them actually occurred within 3 months of transplant, and most of those patients, 8 out of the 9, had received steroids, and 5 of them died of sepsis. So this gets at the infectious complications of ALCHEP and of the steroids that we sometimes use as being an issue in that early post-transplant period. When you get out to 1 year after transplant, it's alcohol. 7 out of 9 of the patients who died after a year was because of alcohol use and because they had gone back to drinking. So the take home from this for me is that it's possible to do this, and it is possible to do it with relatively good outcomes long term. However, you do have to have very robust alcohol cessation efforts after transplant. You have to follow people very carefully and be very selective about doing this. Again, we do not transplant these patients at University of Michigan currently, but centers that are are choosing to do so really need to be aware of these issues of post-transplant alcohol use and that it isn't insignificant. It's one of the biggest reasons why these patients die long term. And so it really makes us points out the need for us to be able to better manage that alcohol use disorder in the long run and come up with some better management strategies, medications, and behaviorally to help these patients stay off alcohol. Thank you.